So I am honored to welcome you all to this significant event, a webinar dedicated to addressing a pressing issue that affects many lives across our community. As the president of the European Alliance of Neuromuscular Disorders Associations, it is my privilege to stand before you today and open this discussion on a matter of utmost importance: spinal muscular atrophy. As you already know, SMA is a condition that touches the lives of countless individuals and also of their families. Its impact, it's not only physical, but also emotional and psychological, extending to caregivers, to loved ones, and to the entire support network. Our organization, AAMDA, is committing to fostering collaboration, disseminating knowledge, and driving progress in the field of NMD. This webinar, SMA webinar, is of course a proof of this commitment that we all do. So I want to thank you for taking your time to participate to this event. And I want to express again a special thank you to our esteemed speakers, as we value their expertise and their commitment in the field. So without further ado, I will pass the virtual floor to my colleague and communication officer, İpek Badurgalı. I'm still learning, sorry, İpek, about this. Who will present our first guest. So İpek, the floor is yours.
Thank you, Arabella. Hello, everyone. It's great to see you here. SMA community, friends from European countries, and also I see friends from USA. It is great to meet our webinar. This webinar is the second edition of our SMA awareness webinar, so we would like to make it periodically each year. Thank you for participating our webinar. And I would like to thank our great speakers who accepted our invitation. Today we have speakers and they will talk about clinical trials, then SMA treatments, finally newborn screening. I would like to present Dr. Robert Graham, which is a very important and impressive person in the field. I know him from QSMA conferences. I have been following up his sessions for the last 3 years, and it is our privilege to have him today. And I would like to give the floor to Rob, and thank you once again.
Well, thank you. Yes, it's a privilege to be with you today. I'm going to try and share my screen, and I'll start with my presentation. And I think as there are other speakers as well, I'm going to cover a lot of material, and I think some of the other speakers will probably expand on some of this. It truly is a pleasure to be with you today, and I understand I'll be able to meet a number of you in person in Bucharest in a month or so, which will be fantastic. So a little bit of background. I am actually an ICU physician. And so, as I often will say, I'm often the person you don't want to see. I mean, you're happy that I'm there if you need me, but you don't want to necessarily need my assistance. But I also run our home ventilator program here at Boston Children's. And so it's sort of in that role that I really became integrated into the neuromuscular space many years ago now. And so really have sort of learned a lot as I've gone along, and had the privilege of working with a lot of individuals and families, and both in clinical care, but also in research. I don't have any disclosures with regards to actually active funding, other than to say that, yes, I've been involved with a number of research trials over the years, and some ongoing efforts, certainly in SMA and in other neuromuscular conditions as well. And so looking forward to sort of sharing that experience. And then I am on a volunteer board for Cure SMA. So what I'm hoping to do today is give a little updates on SMA treatments and trials, and talk a little bit about the phases of research. And I think İpek is sort of participated in these types of sessions before. It's sort of where are we currently, but also how do you want to sort of approach this and think about it as an individual or family member of someone with SMA? And actually, as I think, it's definitely generalizable to other neuromuscular conditions as we think about the new trials that are coming forward in other conditions. And then obviously there are a lot of stakeholders. Unfortunately, not everyone has the same perspective on a condition and the same motivations. And so you sort of have to think about how that affects your experience. And then hopefully we'll have plenty of time at the end to sort of talk about this. So this is literally the tip of the iceberg, as it were, for this topic. I grew up in Alaska, and I'm happy to talk about that, especially when at any point. But I think for me, it's always exciting to sort of reflect on, the two. I remember the two references I went back to look from my medical school textbooks. What was known about SMA, or at least what I learned when I was in medical school, very limited. And to think about how much has changed in that short period of time, or seemingly short period of time, and really some of the most rewarding things that I've seen over the course of a career. I mean, truly, the basic neurology text even noted that we really didn't understand the genetic underpinnings. And, as you can see in the sort of the general pediatric text, really only spoke to the infantile form, the Verdnick-Hoffman, and then the juvenile form, and really nothing much beyond that. And that EMGs were the basis of most diagnoses. So a lot has evolved since then. And that's sort of where we're at now, is that we understand the genetic abnormalities to an extent, and we appreciate the fact when you sort of look at this graph, is like, yes, there's an SMN1 gene mutation, but how an individual experiences their SMA varies, and illustrates that the typing, as we knew historically, is less helpful now in the context of treatments and trials, but it also illustrates that there's still so much that we don't understand in terms of modifiers, positive and negative. And so that happily, and I think been really happy to see that there's, despite the treatments that are available, there's still ongoing interest and efforts to sort of learn more and sort of optimize where we're at. So as I said, it's truly an amazing space that we're in. There are 3 approved therapies, and it's definitely revolutionized, how SMA has evolved since then. And there's also the capacity for early identification and treatment in pre-symptomatic individuals is, life-changing. But there's also sort of recognition that, treatment in those who are already symptomatic, there's significant benefits. And this is actually, for those who've been living with SMA and their families for years and years, this is of importance and something that I think we need to continue to emphasize as we go forward. There's recognition, and I think the 30% of individuals in North America that are untreated pales in comparison to worldwide, the numbers of people with SMA who don't have access to at least even one of the therapies. And this is something that I think is challenging as we as a community sort of advocate and navigate this. Newborn screening is outstanding, and I suspect that others will speak about that during the course of today. But happily, and this is from the Cure SMA website most recently, capturing 99% of infants born in the U.S. are now captured in terms of the screening, which is remarkable and very gratifying. And really makes a difference in terms of, yes, both what can we do from support, but also getting access to treatments early. And then, as I said, most of you are probably aware of this. This is actually really, I have to say, very impressed with this website, interactive and sort of illustrating, yes, where are things throughout Europe and elsewhere in terms of newborn screening, and really, illustrates the fact that sort of advocacy plays a huge part in this, and really will make a huge difference going forward in terms of, again, access to treatments and improving general clinical care. So I want to talk about research. Obviously, the focus is on clinical trials, but I think people should always step back and sort of think about the other components of research that we, as a clinician and clinical researcher, I'm always interested in having people participate in, and that, obviously screening and diagnostics have been a big part of it to just even identify those with SMA. But now I think really one of our biggest goals is the longer term follow-up and how do we sort of assess individuals once they're on a treatment, and how does this change what SMA looks like and what their needs are, and what's the best sort of type of clinical supports that we can provide. And so I think there's a lot more to the clinical trials that are going on, and really, there's no consensus really on what are the best orthopedic interventions, what's the optimal nutrition for an individual with SMA. And so I think there's a lot of things we can continue to learn. I think there's more sort of traction for collaboration internationally and otherwise. And so I think there's still, if you are approached or have, family members or others that might be interested, seek those out, because it's not just about the treatments. It's about how do we sort of improve the global care. But with that in mind, I do want to go through, sort of the currently approved treatments, and then talk about some of the trials that are ongoing, and then how do we sort of think about them. So this is relatively up to date from Cure SMA. It's sort of illustrates the pipeline with the blue bars being the 3 approved treatments, and then everything else thereafter in terms of, ongoing preclinical trials, but also the clinical trials that are going on. So again, incredibly encouraging, given where we had been, and then the fact that even with the 3 approved drugs, that there's still so much going on in the SMA space. And I do think it's helpful to think about what can also be generalized to other neuromuscular conditions. So it really is something that I think, while people are concerned, oh, SMA might be getting more attention than others, I think there's a lot to be generalized, and especially when we think about gene replacement therapy and gene targeted therapies, really essential. So I won't go over the basic genetics, because I would imagine that most people on this understand the basic genetics of SMA, but sort of talk about the different approaches and where we're at. So the first strategy, well, it wasn't the first strategy to be approved, but sort of the most prominent would be true gene replacement. And as most know, that Zolgensma is a therapy that's been approved and replaces the aberrant SMN1 gene. And there's lots of things to sort of consider when we're thinking about gene replacement that I think would have applicability to other conditions when I think about the efforts in myotubular myopathy and other things. And then there's the SMN2 splicing modulation. So how do we take advantage of the sort of backup gene, as it were, and leverage that? And that we've seen quite a lot of success with nusinersen, Spinraza, or risdiplam, Evrysdi, 2 different sort of approaches with a similar sort of mechanism, and certainly something that we we'll get more into and have had incredible success with. But again, from my perspective, and one of the things I'm challenged with from an ethical perspective, is that access to these therapies remains problematic. Certainly even in the US, but worldwide, such dramatic variability. So other strategies, and I'll talk a little bit about these. There are a lot of other approaches, and what these are really often focusing on now is not just the spinal motor neurons, but the muscle, sort of the end game with a lot of in the condition. And so there's efforts to look at neural protection, neural transmission, how do you make the nerves function, those that are preserved better. There's regenerative targets, which is fascinating when we think about what happens in SMN and the survival of those anterior horn cells. Are there things that we can do to sort of help them propagate even after there's been some deficits? And then there's those that are looking at the muscles themselves, and there are a lot of active trials, and I'll go over some of those. And I think it's something that people need to start to think about in terms of combination therapies, and sort of look at how do we optimize the outcome for everyone. I'm going to actually see if I can open up the chat as well, so I can see if there as questions come up as we move along. But so the first and probably most prominent that people are always interested in is gene replacement therapy. So Zolgensma obviously was approved, at least in the US, in 2019 for children under 2 years of age. The European criteria actually are more weight-based, but sort of correspond to that approximately. And as people know, it's a one-time IV infusion. Sadly, in the context of COVID, we all learned about viral vectors and various things, but an attenuated adenovirus vector, so the shell of a virus is filled with a recombinant gene. It has a promoter that's intended to sort of, again, sort of target sort of motor neuron and give you back the copy of your SMN1 gene that you're missing. Obviously very effective. It is cumbersome in terms of the actual provision, and something that has been a challenge, again, in terms of access for folks, as well as side effects, which are not insignificant, and something that we're learning more and more about the more children that sort of receive this. Now, one of the things that's, obviously one of the biggest limitations is that it's only approved for infants. And depending on the country that you're in, it's also only approved for infants with a certain number of SMN2 copy number, and degree of weakness on presentation. And so, again, sort of access not being equal, it's something that I think we have to move forward with and sort of see what's expanding in terms of that. Now, we do know one of the challenges with this is the actual adenovirus vector itself. And that is really a huge limitation when we think about the accessibility to anyone over the age of 2, especially adults who've been long affected with SMN or SMA, and the implications for this. And the primary issue is that the inflammatory response and multi-organ proclivity for the adenovirus is that you can get significant liver dysfunction and other organ dysfunction, and can be life-limiting. And so there has been limitations with that and the immunosuppression that you would have to receive, and I'm happy to talk more about that. But it's one of the reasons why actually Novartis has moved towards an intrathecal trial, and you can certainly access that and see who's eligible and where there are sites internationally that are receiving or that are enrolling individuals with SMA. And this holds a lot of promise, but also cautious in terms of, direct injecting the therapy into the spinal column, and what's the dose, the appropriate dosage is, what are the outcomes. So something to look forward to, certainly. These are actually just sort of a summary of the actual Zolgensma trials and that are ongoing with long-term follow-up. One of the questions that we have long-term is really sort of the durability of this. There aren't a lot of other conditions that we have experience with gene replacement therapy. There are a few, one retinal therapy with gene replacement that's been around for more than 15 years. And there does seem to be durability, but this is also one of the questions as we move forward, is that those who receive a one-time therapy with gene replacement won't be able to get a booster, at least not with the same adenoviral vector, because they'll be immune to it. So following them long-term to see what happens with the strength and endurance and other outcomes will be essential to say, does this last 20 years, 30 years, a lifetime? And, do we need to explore other sort of means of sort of giving them a booster if at some point there's a decrement? So the next sort of approaches, as most know, is sort of, how do we upregulate the SMN2 or, optimize the splicing and modulation of the SMN2 gene? The two most prominent or obvious ones are Spinraza, nusinersen, or Evrysdi, risdiplam. And they are both, the one to make the biggest impact early on was obviously Spinraza, and truly revolutionized where we're at, and gave a lot of people hope, and continues to do. It is truly remarkable when I think about sort of the children and adults that I've been working with, and seeing how it's impacted on their daily lives and really changed the face of what SMA looks like. There are obvious challenges, and accessibility is both a challenge, both country to country, but individual to individual. Depending on, for an older individual, they may or may not be able to get, based on their spinal curvatures and what have you, may be very challenging. And then there's sort of the interruption in your lives and having to come in for injections every 4 months, and the implications for what does this mean long term. But nevertheless, certainly something that we're all very excited about, the ongoing efforts and long-term follow-up. Along those lines, there's also, again, recognition, especially amongst adults, that this is perhaps not, the current dosing regimen is perhaps not enough. And so there is a trial going on with higher dose Spinraza. For many, adults with SMA and even teenagers can say that they can virtually mark their calendars in accordance with their schedule, that they know when that 4-month interval is coming up. And so there's a lot of interest in actually looking at the higher dose or even shortening the dosing interval. And so, I think there's more to come, that the story of Spinraza is not yet finished. And I think that's helpful to sort of appreciate. Evrysdi, again, a different sort of molecule, or it's a small molecule as opposed to an antisense oligonucleotide, but similar action in terms of what it does to the SMN2 gene. But has the obvious advantage of its liquid. It's taken by mouth or via gastrostomy tube, and happily has, again, increased the access for a lot of people. There are side effects that we are still wary of, and I think this is one of the long-term considerations when we think about what does this mean for a given individual and their own lives. I do cautious families, especially of young children who are making the decision to start Evrysdi, that there remain concerns or questions about what does this mean for you systemically. Like, what does this do beyond the nerves and beyond the muscles? Because again, it's an oral med, it distributes everywhere, and SMN is present in every cell of the body. And so what happens when you express it or enhance the expression of this in other organs where it may or may not be most of the time in terms of activity? Most notably, we, in Boston here, we're a little bit more conservative when we follow the eye. We do regular ophthalmologic evaluations, but there is also a lot of uncertainty for reproductive capacity. So working with families, especially for children who are not of childbearing age, is to say, this may impact their childbearing capacity or reproductive capacity in the long term. And do you want to make that decision for them before they're able to participate in that decision making? I'm never good at all of the various fish they used to name the various trials, but this again is sort of a summary of them, and you can go on to the trial websites to look at who was included in a given trial, and actually what there are still some open trials, and certainly the long-term follow-ups and the extension trials. But I think one of the keys is that they were trying to make this available to everyone, and certainly make it an option. Some of the more exciting novel approaches. We've had the good fortune, SMA, as opposed to some other neuromuscular conditions, have had the good fortune of knowing the exact gene abnormalities, and having the sort of backup SMN2 gene as a primary target early on. But there's a lot to be learned from other conditions. And, this is one example, and it may have applicability beyond SMA, is the sort of myostatin inhibitors. So if you were to just go on to whatever search engine you have, Google or otherwise, and put in myostatin mutation, you will come up with both animal and human examples of people or animals that have gene mutations in their myostatin genes. And so myostatin is a naturally occurring substance that actually helps, in some respects, break down or turn over muscle. And if you have a mutation in that, you don't have that capacity. And so, in fact, your muscles don't necessarily, aren't necessarily maintained. They actually just hypertrophy and continue to expand. And so the illustration in the corner is a dog of the same breed, but one with this particular gene mutation. And it's not that they're necessarily stronger, but their muscles are certainly more hypertrophied and otherwise. And the upper corner is an example of an infant, as you can see, with the same mutation, a much more sort of robust muscle than you might expect for an infant or a toddler. And so they're leveraging this to see if it has any advantage in SMA and other conditions. And you can actually see there are 3 active clinical trials, and you can go to each of these respective companies' websites and also sort of the FDA, or rather NIH and FDA and the EMA's websites to look and to see what's active in your area or enrolling. And so there are a number of different approaches, which I'll sort of go through. Oops. Okay. So they have different names. Those with Scholar Rock are actually named after various jewels or gems. And then the Roche Genentech is called Manatee. And then the Biohaven trial is called Resilient. And they have slightly different approaches in terms of the actual therapy, but they are sort of repeated therapies that are ongoing and done in conjunction with a primary therapy. And I think this is something to consider, that this, again, the muscle is the primary target. And I think the one big question that regulators are going to question is, what is the sort of incremental increase, and how do you differentiate someone who's already received Zolgensma, and what relative benefit will they receive from one of these therapies? And the same applies for nusinersen or risdiplam. And the question would be, how do you measure that? And what is significant to the individual versus what is significant from a statistical perspective? And so, I think the verdict is still out on these. I know that some of them are still enrolling. And again, it is worth, if you're interested or have a family member interested, is to sort of look and see what you can access. And then there are still some other trials that are going on, and I won't talk about sort of there's a calcium channel enhancer. This is an example of the chloride ion channel inhibitor. And there are different approaches, again, sort of targeting muscle again. And fatigue is something, especially for adults with SMA, that they speak about a lot. Again, while this is challenging to measure, it is certainly a sort of I wouldn't necessarily even say subjective, but a sort of a lived experience that a lot of these therapies really do help with sort of a daytime fatigue. Even if your gross muscle strength hasn't improved, it does help with your sort of just daily life. And so these, again, in conjunction with one of the other therapies, are holding a lot of promise. Again, not SMA specific. So we may see this, something like this chloride ion channel inhibitor, come forward for other conditions as well. Ultimately, as sort of alluded to, combination therapy is probably going to become the standard of care. It will probably be slow to come country to country once these get approved, because again, it will probably be a function of what's the relative improvement and the cost of these drugs. As I said, there are many stakeholders, and sadly, the cost has been quite prohibitive as we sort of think about universal access, but something that we anticipate. And then for me as a clinician as well, is that sort of triangle in between, or the pyramid in between, is that everything else that we do, we need to sort of keep moving forward with, because if you don't take care of yourself on a sort of day-to-day basis, you won't get full benefit of these gene-targeted therapies or gene replacement therapies. And that's sort of where I kind of think about and transition to, and Ipek has heard me speak about this, is sort of how do we think about treatments and trials in the context of your daily lives and that type of decision-making, and sort of the, is a bird in the hand worth two in the bush, as we sort of anticipate what's coming forward. So I think, with a little bit of a cynical sort of approach, I think it's helpful to sort of recognize that not everything gets published, positive or negative, and a little cynical approach that, the investigators and the pharmaceutical companies may have a different perspective on SMA or another neuromuscular condition than you do as someone who's living with the condition. It can be incredibly frustrating, especially as I think about some of the work I've been doing with the MTM community in terms of how slowly things move forward. and that there may be other motivating factors. At the same time, I do caution people not to jump into trials without being educated about it. That individuals with a given condition need to understand what are the risks and benefits of it. And so whether this is the old Audubon, no speed limit sign, or this, the one on the left is from Montana here in the United States, that the interpretation of what is reasonable and prudent is up to the individual or their family as they sort of make those decisions. I do think it's helpful when we're thinking about treatments and trials is to differentiate, what's a treatment and what's access to a potential treatment in a trial. And that it's helpful to recognize that, if you go to your physician and you ask them, they're helping you with diabetes or asthma or some other condition, that they can tailor the therapy to what you need. That is not the case in a trial. That it is a fixed protocol, and that protocol adherence is essential to interpreting what the response is. And so, if your diabetes is not well controlled, your providers can change how much insulin or what your dietary interventions are based on what your symptoms are and your outcomes. But in medical research, you have to adhere to the protocol, and it's not about you as an individual, rather it's about the pooled results and statistics, unfortunately, or fortunately, your perspective. But I think it's also helpful when we think about enrolling in trials, and happily we have things at all phases of these trials in SMA. And these sort of phases of trials apply, FDA or EMA, in terms of the regulatory bodies. Phase 1 is all about safety. It's not a question of does this drug work? It's about does it cause harm as we move from an animal model to the first provision in a person. These are sometimes combined with phase 2 in efficacy. But when you think about efficacy, it's like, are you blinded? Is there a possibility that you're not getting the drug, that you're getting placebo? And what happens with that? That you may not have any benefit, but you may only get sort of the side effects and really sort of the potential negative consequences of it. And then phase 3, fortunately, as we've moved through, and there are some drugs in phase 3, as I said, the myostatin inhibitors right now are in a phase 2, phase 3 trials. Yes, they're safe. They seem to be effective. What's the right dosing? But then one of the things that I like to emphasize with my families that I work with and the individuals, the older individuals, is that it's essential to participate if you can in the longer term follow-ups, because there are things that we don't know about these drugs over the long term, and that there might be things that could be detrimental for either maintenance or just late manifestations as we think about, something like Zolgensma, which is a one-time dosing. And it is helpful, some basic concepts that I think is helpful when anyone's going into a research trial. The therapeutic misconception is that, again, what is a phase 1 trial? It's about safety. It's not about efficacy. The therapeutic misestimation is that, someone may say, oh, I know it's a 2-to-1 blinded trial. So for every 2 people that get it, 1 person is a placebo. Well, of course, I'm going to believe or hope that I'm going to be amongst those 2 rather than the 1. And so to sort of be realistic about that. And then obviously the therapeutic optimism is that, I'm going to benefit from it, or that the relative benefit's going to outweigh the risk. And so all of these concepts should factor in as you sort of navigate those choices. You want to understand the protocols and understand, eligibilities, like why is someone excluded? And this is becoming more and more controversial and challenging as we sort of think about, especially as adults enter trials who may have other conditions that they've accumulated over the years, who's eligible and who's not. Confidentiality in the neuromuscular community is challenging. Everybody knows everyone else, or is oftentimes the case. And so certainly early on in the SMA trials, it was really difficult. There were huge schisms amongst the SMA community in terms of those children who were included and the families that were included and those who were not. And it became very contentious and actually quite divisive, and was really difficult and hard for families to navigate sometimes. There's a lot of commitment to participate in trials, and the impact on family can be huge. That may entail a lot of travel. Ideally, if it's a trial, that is a sponsored trial, you shouldn't have to pay for anything, but there may be other costs. You may not be able to work on a regular basis or attend school or otherwise. And so it's something to think about as you move forward and make those types of decisions. And then, there's the protocols, but then again, there's everything else that rolls into it, and where we are in SMA. And it's getting more and more difficult when we're working with regulators in terms of, who's eligible. Like the SMA typing historically was, well, I wouldn't say easy, but more straightforward. An individual with SMA type 1, 2, and 3 were more readily differentiated. Now on various treatments, as we're looking at combination treatments, that typing is actually almost meaningless. It's more about what is their relative function and sort of nuances of that. And then, for you as an individual, the question is, are you doing okay? Do you want to be better? And what are the risks of, the enemy of good is perfect? Is that, will you have more challenges with something that incrementally may not make you that much better? And then, a lot of these other issues I'll sort of leave, but I think, the progress that we've made in SMA may conceptually slow down a little bit, partially because so many people have access to therapy now that you don't have the benefit of having treatment naive individuals as much. And so to demonstrate that something's efficacious is becoming harder and harder as we sort of think about the combinations. I think the pharmaceutical companies and the researchers are recognizing that, yes, they are looking to countries worldwide. And so I think as you're looking at protocols, there may be more eligibility elsewhere, and they may be supporting travel because everyone is going to need access to those who haven't had it previously. And then again, as a clinician, one of the things that I try to work with families around and individuals is that we need to continue to optimize your clinical supports. So, if you needed BiPAP going into a trial, you probably are still going to need it afterwards. If nutrition was an issue, or even going in or maintaining it, then we need to think about feeding tube options and orthopedic interventions. If you have pain or limitations in your daily life related to orthopedic issues, you may not want to put those off, hoping that it makes you eligible for a new trial coming forward, because what happens with that new trial is impossible to predict. And so you need to sort of focus on your sort of maintenance of your own health going forward. So it was a lot to cover in a short period of time. Hopefully I've covered a lot of that and left time. I know the webinar continues to go on, but I want to leave time for questions and really sort of give people an opportunity to sort of share their experiences and go from there. I want to thank my team members for my home ventilation team, obviously the EAMDA. Dr. Daris is our lead neurologist here and is, leads our neuromuscular clinic and our SMA clinics. I've also provided the links in the blue. Clinicaltrials.gov is the US-based sort of repository, but also the clinical trials Register EU is a fantastic resource for saying, what's available within the EU and the EEA. And so I think definitely places to start if your local providers don't know of what's available to you in terms of trials. You can email me at any point, and I'll stop share here, but open up for discussions.
Thank you so much, Dr. Graham, for this very insightful presentation and very interesting facts that you shared with us. And thank you for making time for being with us today. So I just want to see if there are any questions. I could not see anything in the chat, but maybe someone wants to give a feedback or just have some questions for Dr. Rob. You can just open your microphone and speak, so no problem there. Samad, if you want to open your microphone, it's okay.
I also put my email in the chat for those if you want to email me later or otherwise. So.
Hello, everyone. Firstly, thanks for sharing this excellent information with us. I am from SMA, Azerbaijan, and I have one question about Zolgensma. Intrathecal Zolgensma infusion results. What results, good or not?
Yeah, so they haven't released much. I mean, I have interesting. They are they're looking to broaden sites because there's been difficulty enrolling individuals. Again, mostly related to sort of eligibility. I believe in Boston we've only been able to enroll one person. And it really does have to do with they're so stringent on what's your functional level beforehand. Because they have to, again, you have to be strong enough, sort of muscle function has to be enough to show that there's a benefit, but you have to be old enough to participate in the outcomes. It's really sort of difficult in terms of that. To my knowledge, and they haven't really had much release, it's been tolerated. So from a safety perspective, it appears to have been well tolerated. But the outcomes, they really haven't put any publicly available outcomes yet. And actually, as one of the sites, we're blinded to that as well. I'm hoping that will continue to sort of roll out within the next year. And it does hold a lot of promise.
And I have one additional question. How results after 2 years aged Zolgensma infusion? How outcomes after 2 years aged?
Oh, beyond, so this is very difficult. And I think this is something that, I work with families actually quite extensively, is sort of understanding before. It's less for the pre-symptomatic. There's fewer questions, but because if you're pre-symptomatic, presumably you have maintained your anterior horn cells, your spinal motor neurons are still intact, or that there's minimal sort of apoptosis or atrophy there. For those who are symptomatic, I think first issue is that there are nerves that have been lost already. And that you're not going to be able to resurrect those, but the hope is that by maintaining, the Spinraza or risdiplam as well, is that by maintaining the nerves that are still there may be opportunities for arborization or branching of the motor neurons that are still there, and reinnervation of other muscle bundles, and so that there might be some, preservation and even recovery of muscle function as far as that's concerned. If there's been a significant loss, then that's probably can't be resurrected. And so I think this is one of the challenges. And then there's sort of recognition that individuals respond differently. And this sort of speaks to that there are other disease modifiers, good and bad, that we don't understand beyond the SMN2 gene. And so I think this is very difficult. There's some evidence that there might be some swallowing recovery for those who have in the long term, but again, it's so variable. It's impossible to predict, and I think it's something that when I'm working with an individual family is very clear that expectations are difficult to align sometimes with the outcomes. I think long term we'll learn more and more. I think the combination therapies will probably be helpful. So I think it's difficult to sort of give a single answer, other than that there continue to be long-term follow-up studies for all three of the approved treatments.
Thanks.
Are there any questions, comments?
Well, if not, I do appreciate. I'm looking forward to meeting a number of you in Bucharest, and this has been great. Again, please feel free to email me. Don't hesitate.
It was an amazing presentation. Thank you, Rob, so much. I mean, it summarized the basically what we know or what we stand with as regards therapies for SMA and clinical trials. So it was very, very good one. Thank you.
Thank you so much, Dr. Rob. I have a question, actually. I have two questions. I would like to ask first. I would like to, there's a huge discrepancy between the countries. Most of the countries, they do not have clinical trial sites. For example, I can give you an example from my country. We don't have we only had Nusinersen clinical trial in Turkey, but since then we don't have any clinical trials, and there is no evidence that there will be upcoming clinical trials. But from the patient's perspective, I can say, because most of you maybe know that I am an auntie of SMA type 2 girl. So she is 9 years old and she is on Spinal treatment. So I am questioning this thing. I cannot go to a European country mostly because most of the countries give priority to their people. It's normal. But my question is, if it is possible to make a percentage, for example, they can give like 10% or 20% to the other countries which do not have clinical trials. Is it possible? And who can give this decision? Does the sponsor, the pharma company, give this decision, or does the site give this decision? Because if we can make this thing happen so that more countries can access to clinical trials. But I know from my personal knowledge that it is not possible to go to, for example, Italy or other countries because they prioritize their people. And maybe after that, I will ask my second question.
Yeah. So, I mean, I have to say this is, yeah, these are huge ethical issues, and it's tragic, actually. As I said, this is one of the challenges that I think we face, and actually I think the EMDA is probably well positioned. I mean, sort of the advocacy, even for approved treatments, let alone trials, there's so much variability. Even if something is approved in a given country, actually the criteria to receive it are highly variable. And so I think obviously there's cost is probably one of the biggest drivers of that. It certainly is. And so I think, advocacy groups like the EMDA, Cure SMA Europe, they have a huge amount of, honestly, power, and working directly with governments and regulatory agencies is essential, even for the approved therapies. And I think the more and more, actually, and this is one of the valuable things about participating in even just natural history trials, is that we need to have more and more published evidence to then bring forward to the regulatory bodies and the payers and the governments. So it's essential. In terms of accessing trials, yes, it really is up to the sponsors. I mean, we've had a lot of families from abroad come participate in trials with us here in Boston. They've been from the sponsors themselves from South America. We've had some Southeast Asia, a number of other countries, actually Turkey historically, but they've all come under, yes, the sponsorship of the primary pharmaceutical company. So I would say it's, yes, you can approach the sites, you can go to the, look and see what trials are open. You can approach the sites, but ultimately it has to go through the sponsor, because again, it's, for something like Zolgensma, the early trials, it's a commitment of at least 3 to 4 months on site and then regular follow-ups. And so very few for 4 months at a time. And so, yes, the support from a sponsor is essential. And I think, I suspect that the sponsors will become more and more receptive to it, as they need to have access to people who don't have it. Now, that obviously puts you as an individual or an individual's family in a vulnerable position. Like, you might be willing to do anything to get into a trial. And so it's challenging, but I suspect that there will be more and more opportunities, just because, a lot of the sort of North American based sites and, you know, the Western European sites, most individuals have some access to something. And so there won't be treatment naive people with SMA going forward until they sort of expand where these trials are being done.
Thank you so much for the detailed information. My second question is about the muscle enhancement treatments. In QSMA, I had a chance to see the poster presentations about them. I would like to double check my information because I was thinking that for biohaven treatment, it is applied daily. You apply daily doses at home or
It's
not?
Yeah, no, I believe the Biohaven, I'm almost certain that it's a weekly treatment. So
Ah,
all of these again, so there was, and I'm always cautious with, there was a Cytokinetics, John Day, who was at Stanford, had a calcium channel enhancer that was in trial, actually had some efficacy, but they essentially ran out of money and weren't able to do longer term follow-ups or show, and that they needed to show a statistically significant improvement. And so, you know, I suspect that will come back at some point once they find a new sponsor. The chloride channel therapies, as I said, are coming along. But yes, the myostatin inhibitors, they all have different sort of, you know, there's subcutaneous and then there's the IV formulations. They're all a little different. They do require either, I believe it's weekly for the Biohaven therapy. I'd have to look back. And certainly at least monthly for the others. And so those are things you sort of have to think about in terms of access. And they would really only be complementary to, you know, either Spinraza or risdiplam or Zolgensma, is that they, you know, alone, they may have some benefit, but they don't sort of halt the progression of the motor neuron changes.
thank you so much, Dr. Rob. If no one has questions, I would like to ask once again, if anyone has questions, you can directly jump up to, to the discussion. And I would like to let you know that Dr. Rob is going to be one of our speakers in our annual Neuromuscular Disorders conference, which will be made at the end of September in Bucharest, Romania. So it will be great to have you there in Romania. Thank you once again.
Hello, my name is Andreea, and I'm from Muscular Dystrophy Association of Slovenia. I have two questions. As a clinician, Dr. Rob, I wondered, do you have any situation that the parents doesn't decided to cure with Zolgensma?
Yes, I mean, we continue to, I mean, partially, you know, at least fortunately in the US, although it's not uniform from state to state, they have access, you know, a newborn diagnosed. And again, the newborn screening, which I was thrilled to see, there's still so much progress happening in Europe. The newborn screening is probably one of the biggest, most revolutionary things that we've had in SMA now that we have therapies. We've had families choose not to do gene replacement therapy. They have concerns and not unjustified of potential side effects. Fortunately, they also still have the opportunity to say, you know, perhaps we want to start with one of the other therapies and then revisit this before the child is 2 years of age. Payment is always an issue, certainly, depending on insurance status. And again, it varies from country to country if it's a state-sponsored payer or private insurance. You know, we've definitely had some. I would have to say, when Spinraza was the only option and we had families opt out of any treatment and at all, even though that Spinraza was being offered, I suspect we will be entering an era where, as things become more universally accessible, that there will be questions about a family if they choose not to have any treatment. Like, is that ethically allowed? But yes, we definitely have families who've chosen to do Spinraza. We've had families who've chosen to do Evrysdi or risdiplam instead of gene replacement therapy. There really is no head-to-head comparison is one better than the other long term, and I suspect that it may vary. Again, it may be very depending on the individual, but so yes, it's I think we have the luxury that families have choice here. That's not the case, as Ipek was saying, like in Turkey, like there is one choice. And so, yeah, I think it's something that, it's great to have these options. It is remarkable as I think about what's happened.
Yes, I agree.
If I may add,
second question is related to Spinraza. Are there any possibilities that the doses of Spinraza could be shortened to 3 months?
Yeah, this is something that was actually we discussed, because even in the trials, there was actually a shorter dosing interval early on. And so, Biogen ultimately decided to go with the higher dose as opposed to shortening the interval. I think this is still an area that might be worth exploring. And I think they are considering this because, the question will be, is there some toxicity from the higher dose that you wouldn't necessarily see in a shortened interval? So I have to, this is just sort of personal. I think that might be a better way to approach it when we sort of reflect on some of the animal toxicity that there was early on, in the preclinical phases, is that the higher doses were a problem. And that's how they arrived at the current dose. And so it may be that actually, yes, that in long term, they may go to every 3 months as opposed to every 4 months. But we'll see if that that's a little ways off. But I suspect that might be something.
Okay, thank you.
If I could say a few words about both questions, maybe about Spinraza. On one hand, yes, shortening the time between the doses might offer clinical benefits. We don't know it yet. It is worth perhaps it could be studied. On the other hand, Biogen has to has to balance the patient acceptance, whether treatment so frequent would be accepted by patients and by payers, because it's always a hospital visit, which, all right, in Europe is not that costly, but a hospital visit, a stay in a hospital in the US can run up to, let's say, $10,000 a day or more. So whether that would be something, a more frequent dosing regimen would be accepted. Right now, Biogen, as we can see, are trying to look into spacing the doses even further, increasing the doses and having the drug dose, let's say, every 6 months, or potentially with a new molecule every once a year, just exactly to have the treatment, to have fewer patients switching to competitors' treatment, because the biggest appeal in Evrysdi is the ease of use, the comfort of use, right? We don't have any other data that would show superiority of one of the treatment over the other. So that's one comment. Regarding the use of other treatments, I think there's a very beautiful 2 paragraphs in the publication on the German newborn screening pilot. And they quote, I think it's Wolfgang Faber-Müller. He wrote that paper. He says that after confirmation of, that's a quote now, after confirmation of the diagnosis of SMA, 52% of parents opted for therapy with onasemnogene abeparvovec, 14% for treatment with nusinersen, 16% for therapy with risdiplam, and 18% for a wait-and-see strategy. But in the group with 2 SMN2 copies, 85% opted for gene replacement therapy and 15% for nusinersen therapy. So we see it's not, I mean, the decisions, parental decisions, and actually the joint decision-making model in Germany, where the decisions are taken jointly by the clinician and by parents, it's not just, okay, we all go for one specific treatment and we forget about everything else. In some cases, other treatments or other considerations might be important as well. And I think it's very important for our community that we have as many treatment options as possible.
And I think it is important. Actually, it highlights a point, is that part of what I think actually the EAMDA will be very helpful for as we sort of think about gene replacement efforts in other conditions as well, sort of education around what it is, because some of the hesitance is sort of just not understanding what it is that's happening, like that you're not modifying someone's genome, you're adding something that's not even integrated. It's just there in the cells, and people are worried about sort of what does that mean to them as an individual, and that tinkering with someone's genes may be problematic. And so I think it's helpful to sort of to help with sort of the education component. But again, yes, you're right. I mean, it is having a choice in this is essential, and it's actually been quite helpful.
Yeah, well, I recall years ago when the question of Zolgensma came before EMA, the European Medicine Agency. Apparently, there were reservations from EMA on the use of the term gene replacement therapy. They preferred and they still prefer gene therapy. You don't call it replacement because this can be misleading. Yeah,
Right.
I'm not sure whether they've changed their mind now. I haven't tracked it, but initially it was not called gene replacement therapy in the EU.
I see in the chat there's someone asked about delivering new motor neurons. So there has been interest in the past for stem cells. They have not been efficacious. Actually, interestingly, there's probably the most sort of active efforts in that is actually in spinal cord injury, in acquired spinal cord injury. There's obviously been a lot of efforts sort of in that realm. It really haven't been that efficacious, partially because although there is some progress, it's a ways off in terms of how do you get a stem cell to differentiate into the cell that you want it to be. And so it's not that yes, people are looking at that. It is, I think, a lot farther off, although as fast as we're moving these days with progress in the neuromuscular space, it's hard to say. I would caution people. I do remember it wasn't that long ago that at the SMA conference, families were being approached by, actually there were several around the world, people who were professing to actually have a cure and to be able to replace motor neurons. They were asking families to pay about $50,000 US to participate. It was all a hoax or a scam. And there were actually families who actually went, and children have had major complications. So one of the things when I'm working with families is to caution them to say, is this truly a rigorous sponsored trial? And if that's the case, you should never have to pay a thing to participate in a trial. If you're having to pay for it, this is not necessarily something, or you should question that, I guess. So yes, the short answer is nothing yet in the replacement of motor neurons, but it's on the horizon, and people are still interested because it's not specific for SMA. It would be applicable to a number of conditions.
Question, because I think there's an agreement. Stem cells is a quackery right now. Stem cells for SMA. I mean, it's just plain and simple. There is no science behind it. It's just pure selling, magic potion. But there was a very recent publication in the Science about base editing in SMA, and that's something that looks quite promising. I admit I have no idea about base editing, and maybe you would be able to say a few words whether there is any promise in that.
Well, I'll have to look that up as well. I mean, I have to say it is truly, the neuromuscular space is again, I'm coming at this from a different training background and otherwise. The neuromuscular space has been fantastic to watch evolve and to participate in over the years. And I have to say, I get as much going to the neuromuscular conferences as more than I actually contribute, because yes, this is evolving so fast. And the CRISPR technologies and the base editing, I think we are going to see huge changes across the conditions, certainly in the next 5 and easily 10 years.
All right, I posted a link in the chat if anyone's interested. So this is the open access publication.
Actually, it's from someone just down the street from me. I will have to look at. I will send out an inquiry. It's from a lab down the street from us. But good. All right. Well, it's been a pleasure. I apologize. I am going to have to step away to another meeting, but I look forward to seeing many of you soon.
Definitely. Thank you so much once again, and it was a pleasure having you. See you in Bucharest.
Thank you so much. See you in Bucharest. Thank you.
Okay, so moving on to our next speaker, I want to introduce you to you Dr. Oana Vladachenko, who serves as a committed pediatric neurologist at Dr. Victor Gomoiu Children's Hospital in Bucharest, Romania. Her expertise lies in the field of pediatric neuromuscular and neuroinflammatory diseases. She specialized in this field both in Romania and in France, equipping herself with comprehensive proficiency in diagnosing and treating children with NMD. And I also want to say that she's a special friend and also the doctor of my two kids with CMT, with Charcot-Marie-Tooth disease. One of the many doctors, because they are in their hospital, they have a dedicated medical team on the neurology department. So wanna welcome and thank you so much for accepting our invitation. The floor is yours.
Hello, thank you so much for inviting me. It's an honor to be here. As Arabella said, I'm a pediatric neurologist and I specialize in neuromuscular disease, especially in neuroinflammatory disease, but this is another story for another time. I would like to start my presentation by saying that I want to talk about a little bit about the clinical experience and the clinical results of treating children in our hospital, and regarding the new therapeutical choices that we have. I think it is important to be aware of the fact that we still need to respect the standards of care regarding the therapy we receive. I will share my screen now. I hope everything goes well. Okay. Is it all right?
Yes, it is. We can see it.
Thank you. So I won't talk very much about the definition of the disease. We all know the genetic defects and how the modified SMN1 gene can harm the functioning of the muscular system, of the nervous system, And I will just jump on and say that in our clinic we have a multidisciplinary team that is very we always try to and enlarge our team in order to have all the affected areas that can be affected in the SMA clinical picture. I would like to start by saying that we have we can have a prenatal diagnosis from starting from the 10th week of gestation by chorionic villi or amniocentesis, and knowing this, we have to pay a lot of attention on the neonatal screening. Unfortunately, in Romania, we don't have a neonatal screening for SMA, and this is a problem we fight a lot for. and we try to convince the government and the authorities that this is an important issue that will not only save lives and better the quality of life of the patients, but it will diminish the cost of the public authorities when treating our patients. So this is a problem that we are very concerned about, and we try to raise awareness, and we try to make everything possible so that our authorities can involve the screening of SMA in the national neonatal screening. In Romania, we have all 3 treatments available. The first one was nusinersen that was approved in Romania in April 2018, and in October 2018 was the first administration in our country. In our hospital, we started to have the administration since January 2019. And risdiplam also is a treatment that is available since 2022. It was the second choice, I think, for most of the countries. And I found out that although it was an easier way to receive the treatment by oral administration than intrathecal administration, families weren't so keen on changing the treatment. And Robert said something that was very interesting, and I will get to that later, that meanwhile expecting clinical trials and the cure for the disease, there were a lot of patients that neglected their skeletal abnormalities, and they delayed their scoliosis intervention so that they could be involved in the clinical trials. And as we will see later on, this was a very impactful choice made by the parents, because their children are getting bigger and severe deformations that it is very hard to correct. And in January 2023, finally we get the Zolgensma approved in our country, and we have some patients that were very eager to receive the treatment, and they were very enthusiastic. The community was very enthusiastic about the treatment. I have to say that given the fact that in Romania we had the Zolgensma approved only this year, at the beginning of this year, there were a lot of patients of ours that chose to have double therapy. So they had nusinersen in Romania, and they went to different countries to receive Zolgensma. And this was a very challenging thing for us to. Of course, we encourage them to do anything that's best for their children, but they still had to come and receive nusinersen because they didn't want to lose their right from the national program. And of course, their outcomes were better than for the other children. But we have to say that for now, because we have Zolgensma in Romania, things got a bit different. And most of the families of the SMA1 patients are giving second thoughts to which therapy to choose, because now it's a little bit harder for them. So as I said, our first nusinersen administration was in January 2019, and this is the girl that I was talking about earlier, that at the age of 14 received the first dose. Meanwhile, since 9 months of age, since she was diagnosed, until she was 14, when the medication came to our country, her scoliosis got worse and worse. And it was very hard for us as neurologists, for the ICU doctors, and also for orthopedic surgeons to inject her. So this was an effect of the fact that her parents were very keen on completing the criteria for enrolling in clinical trials. And it's totally understandable, but it is also a little bit facing reality today. It is a bit challenging for the family and also for Wana and also for us. And when talking about her, it was very interesting the fact that even though we have reached the point where she couldn't be injected anymore, we tried to, and we succeeded in injecting nusinersen under CT guidance, and she prefers going on with the nusinersen treatment than switching on with the plan, which it's not a very natural thing to do, but they really trust the treatment and they chose to go on with it, and they refuse to go on with the plan, and she's still injected under CT guidance. We first started very carefully the pre-injection evaluation, and at first because families were really scared and they wanted to their children not to be very traumatized by these injections, especially considering the fact that at first they were given 4 injections under a very small interval of time. So we talked with our ICU specialists, and they always give us a little bit of anesthesia, especially for small children and the children that are very, very anxious. As I said before, Wana was first, her name is Wana, was the first patient that was injected under CT guidance, and we were the first center in Romania to do so, and we still remain the first pediatric center to perform it in children. And this was the first. This was actually we had to film every intervention, and we had to film every injection at first in order to prove that we are very careful and we inject the whole package and so on. There were very interesting times, I should say. And we started to evaluate the patients that were injected with nusinersen using functional scales. And as we know, we use the CHOP intent for SMA type 1, the HINE for 1 and 2, the HFMSE for 2 and 3. We use the ECA2, the RULM, and the 6-minute walk test. And we discovered that the patients were not really compliant during the evaluations in the clinic. So we always rely on family videos also, because they're very useful, and the children collaborate with their own physical therapists better sometimes than with ours. And because we have a lot more experience with injecting nusinersen rather than using the other 2 treatments, because they were only approved, as I said later on, sorry. We try to make this kind of evaluations for them periodically, and we saw, of course, that the scales were going up. But there were some times these evaluations were made during the pandemic period, which was a very hard period, because they were coming to have their treatment, but meantime they didn't have as much physiotherapy and respiratory physiotherapy as they did beforehand, because they were everyone was very afraid of getting COVID, of the complications of COVID in the neuromuscular patients. So there were some times when the scales went a little bit off, but generally speaking, all in all, things got extremely better, and we saw that. Of course, the type of SMA was very, very important, but we saw a very evident evolution coming from the number of SMN2 copies. So this is a fact that is well known, that patients with more copies have a better SMN2 copies have a better outcome. I will show you some videos right now from our patients. They all agreed to be seen in these presentations. Here we see Matthias. He's a type 1 with 3 SMN2 copies. I think this video was made by the family after 2 doses of nusinersen, and some time ago he manages to use his small bicycle like almost like any other kid his age. Now it has passed some time, I think 6 months from this video, and now he's getting better and better. So his evolution, his motor evolution is absolutely great. Here we have Nicholas. With Nicholas, we had some issues. He's a type 1 with 2 SMN copies. Now he's done 14 doses. What I want to show you with Nicholas is that he received his first dose at 3 weeks of the age, which is early, considering the time lapse between the symptoms and the diagnosis in our country. Because he comes from the countryside, and the access to professionals is not very good. But he was doing very well at first. After that, we found out that the family didn't do much physiotherapy with him, and then he started losing weight. He started to not go so well on the scales. And we decided he had BPAP from I think 3 months of age, but the parents used it on an on and off basis, and we decided to go on and have feeding tube or gastrostomy. And after the gastrostomy, he even though he did his administrations as he did before the gastrostomy, he was very well afterwards. We see him now very joyful, singing and dancing in his chair, and with evolution that was seen in the motor areas, as well as cognitive development, because we sometimes forget that our patients, especially type 1, can have a cognitive deficit and can have delays in acquiring language, and maybe there are some patients that have started to develop autistic features and hyperkinetic features and so on. So we try not only to evaluate their functional scales, but also to do a psychological evaluation from time to time to see where they are in this part of the development. Here is another Nicholas, but he's a type 2. He has 2 SMN copies, and by now he has done 18 doses of nusinersen. This is after 6 doses, if I'm not mistaken. And at first, the family have seen a very evident evolution, especially motor. He's a very nice child. He always tells jokes, and he's very fun. And oh, sorry. Here we can see him. I'm sorry for the video, for the rotation of the video. Here we can see him in a standing in an orthesis that maintains his orthostatism very well, and he manages to be fixed in a straight way, which is very helpful for his spine especially. Another case that was it's very close to my heart is Amalia. She's type 2. She has 3 SMN copies, and we should see the difference between her and Nicholas. She's very, very well taken care of. Here she was an infant, I think. She was about 1 year and 3 months of age. She couldn't walk by her own, but she had not a very important delay. And some time ago in May, I think, we received another video from the family that showed Amalia dancing with her friends and being very joyful and having, as we can see, a quality of life that is amazing for her. We can still see the proximal deficit, but it's amazing. And we returned to Wana. She was one of the first patients that were injected in our clinic. We can see this was a picture taken when she was 16. Now she's 18, with a very, very hard. We transitioned her to the adult facilities. And it was a very, very big moment for both for Wana and the family and for us, because I think she was one of the first SMA patients diagnosed in our clinic when she was an infant. Here we can see Wana at a small age. She was a chubby with a straight spine girl that was given mechanism based by her father to walk in the house and to be able to walk, to be transported in the house and to enjoy the environment, her environment. But we can see her here after the second dose that she used to use very well her hands. But meantime, the deformities were very important, and as I said, we need to use the CT guidance to inject her. And this is our chief of radiology that manages to get it done. Here are 2 sisters, Maria and Theodora. Maria is the eldest child, and her symptoms weren't that obvious at the beginning. But when Theo came, symptoms were very, very important. So they came in our clinic with both of them, and we diagnosed Theo, and after that we diagnosed Maria with type 3 SMA with 3 SMN2 copies. With them, it was a great challenge for the family and for us also, because she wasn't able to be injected at the same time as her sister, and we tried very hard to make the authorities get her the injection in the same time as Theo, but Theo has some administrations. Some supplementary administrations, and they all have a beautiful evolution. Coming back to the multidisciplinary management, which is a thing we do all the time, we always and we try very hard to put the families first, put the patient first, and to, when they come visit us, to have all the consultations done and to have the injection done, and to be seen by an orthopedic specialist, by a psychologist, by a pulmonologist, and always a nutrition specialist, and if needed by a surgeon, when the gastroenterologist thinks, and we think also in the family, that it's time for alternative ways of feeding the child. We have a very close collaboration with our genetic specialist, and we have a very good rehabilitation specialist also. Of course, as I said, the family is the first one to lead the team, and they lead the team by choosing the neurologist, by choosing the treatment they think it's most appropriate for their child, and we try together to involve in a proactive care when talking about the treatment, when talking about the monitoring and the progression of the disease, and of course avoiding and delaying the complications. But if we can't do that, of course we need to think about treatment. We have our orthopedic specialist. This is the preparation of a spinal surgery. We need to say that they are very, very involved, and they help us a lot and they support us a lot when talking about bone deformities, when talking about spine deformities, as well as feet deformities and so on. And during surgery, they use this intraoperative monitoring care. So we are sure, and we try to avoid complications of the surgery itself. This is the operation table that turns around in order to be very comfortable for the patient and for them also to have the spine upwards. Here we have our respiratory care ward. In all the wards of the hospital, we try to find people that are very passionate about this kind of health issues, and we have managed to gather a very wonderful team of neurologists. That we have the PSG done every 6 months or every year, or if it's needed earlier on. We try to have all the patients on all the SMA type 1 patients on BPAP, and this is a thing is a thing that is very important for us and for the patients. And talking about respiratory issues, I would like to tell something about what we were talking before with Rob and with you. The duration between the two administrations, so 4 months. I don't think that families came and told us that they see that the child starts to have a decrease in their motor function, and most importantly in the respiratory function after 3 months. And it was them. They told us that they are worse during the 3rd and 4th month. So I think for some of the patients, this would be a thing that they desire, to have the injections at an interval of 3 months. And we saw that too, and we started to have in between evaluation of motor function, and we've seen that it's better at 3 months that it's in 4 months. So I think this would be a great idea if we could take into consideration, if Biogen would take into consideration maybe to have a clinical trial, or to have some trials in injecting the substance earlier. But of course, as everyone said, we should be very attentive to the side effects and to the accumulation effect in our patients. So this is the BPAP we use. We use also the cuff assist. Every family has a cuff assist and that they use, and they started to be very careful about their respiratory care, and this is a thing that I am very happy about. Here is Nicola's mother, that is very knows very well to put the mask on. And I have to say that now, after the family understood how important is the respiratory care, how important is the nutritional care for Nicholas. And now he doesn't want to sleep without his mask. And at first he always tried to reject it. But now, because he feels great and he sleeps very well, he asks the mother to give the mask. This is a child that is having a PSG. I've already talked about the nutritional management and the swallowing difficulties. I should say that we have a very passionate endocrinologist that takes care of the risk of osteopenia and the fractures, and she's very careful with the calcium supplements and vitamin D. And in our hospital, the surgery team also performs gastrostomy interventions, and they do it very well. And the care, the post-operative care is very well done. I have already said that how important the physical therapy is and how important the respiratory care is, how important it is to have very very good orthesis and sitting support and all kind of wheelchairs. And we have some patients that have like a scooter that they use, and they are very happy with them. And of course, they have this kind of old supporting devices and the functional training for the upper limbs. And of course, the alternatives like hydrotherapy, which are very calming and are very pleasant for the patients, are done on a regular basis. I would like to say that we've seen that communities are very important for neuromuscular disease patients, and how well they feel together, and how happy they are, and how joyful they are when they are together. When they come, we try to call them almost all at once, and they have like little groups of friends. They stay together, they play together, they play video games together, and it's very important for encouraging them to play, to go to school, to have hobbies. We try to raise awareness amongst teachers, amongst the colleagues, amongst their communities, and we now the talk about transition has become very, very hot, to say so. And we try to go and talk to adult neurologists about our young patients that they will have to treat after the age of 18. And it is true that it is a very new problem for them. And sometimes they can be skeptical, sometimes they can be a little cold, but we try to get together a group of adult neurologists in order to have the transition process very smooth. And of course, this means that they can have more independence. We try to encourage them to choose their studies, to choose their profession, to start a family. And we think that in our days, when we have treatments, when we have access to therapies, to multidisciplinary management, they become like flowers, because they know they can do things as well as their potential. So we are trying to be very supportive of them, and we are always happy to see communities very well bonded and very well formatted. Considering what we have talked about and what the earlier presentation was about, I think we are in an era that is very illuminated, let's say so. I remember when I was a first-year resident, it was one of the first patients that I've seen in 2013, It was an SMA type 1. And I have to say that we, apart from the palliative care, we just watch him go. So it was, he had very blue eyes, and I remember those eyes this day. He had very blue eyes and very, it was very hard for us to let him just go. And I think we are grateful very much for the times we're living in, because as I said, I think they're illuminated times. Thank you for having me again, and I'm in your admiration for creating so strong communities, and for the fight you have in you. I admire you a lot, and thank you. And we shall meet with some of you in Bucharest in September. Thank you.
Thank you, Anna, so much for this wonderful presentation. I personally know your work there, and not only your work, but your colleagues' work, and the hospital you work in, as I think at least twice or 3 times a year, I go there with my kids. So you are doing there an amazing job. And even from a patient perspective, or from, let's say, a parent perspective, it's so encouraging for us caregivers, patients, you know, to see so much dedication and such a wonderful team, and everyone smiling at you and explaining. And so I really wish that all patients all over Europe, all over the world, would benefit of such professionals as you. And I'm really grateful that I found you. Actually, I met with Dr. Raluca Teleanu, the head of the neurological department there, at Eurordis membership meeting in 2019. And that this was a door open for me, as my oldest son is also with epilepsy. So that's why I choose to travel across Romania to get to Bucharest, just to know that my kids are very well taken care of by professionals. So thank you so much for sharing.
Thank you for your kind words.
And I think we also have a question for you in the chat. I see Liv, you
yes, I see a question. This is a very delicate subject, because the members of the medical commissions of the Minister of Health changes, and their members change, and I think from talking to them, they all want neonatal screening. It's true that we have to be very determined, and we have to be there all the time in their neck, so to say, because if we don't do it, if we and the communities together don't do it, they won't do it by themselves, because we know how the system works in Romania. I would truly love to have neonatal screening, and to have not only SMA. Of course, SMA is the topic that is we're talking about, but there are ways to have SMA neonatal screening and other genetic disease that have treatment. This is the thing. We need to have newborn neonatal screening for the rare disease that have treatment, and there are not so many. And we're trying to fight for this. But I'm not a member of the health commission, so I can't know what is their opinion. But in not on the official event, maybe in the official events also, but when talking to them, everyone is very eager to have the neonatal newborn screening. Thank you for your question.
Are there any more questions for Juana? or comments?
I'm sorry for the videos. I'm really disappointed they didn't turn.
Don't worry about it. If there are no more questions, I just want to let you know that you will meet with Oana at our conference in Romania in September 30, October 1st. So you will have your chance to put your questions there as well.
Thank you so much for inviting me. It was a pleasure.
We are honored to have you here. İpek, back to you.
Thank you. Thank you, Dr. Ona. It was great to hear about the real world evidence. It is always helpful and to learn the advancements in SMA treatments. Thank you. And before passing to the next speaker, may I ask all participants to open their camera so that we can make a group photo for regarding our webinar. So then I would like to pass the floor to Kasper.
And I just want to say that you will have to get used to these requests from İpek, as she's our communication manager. So she needs good photos for the social media.
Thank you so much. So I am making it. I will make 2 or 3. One more, please. Done. Thank you so much for this opportunity. Yes, I think, yeah, thank you. Thank you so much. So our next speaker is Kasper Ruczynski. Thank you, Kasper, for accepting our invitation and being our speaker second time, because Kasper was among our speakers in the first edition of SMA webinar. Kasper is the founder of SMA Poland organization, and also he is a committee member in SMA Europe's Newborn Screening Alliance. Thanks to SMA Alliance, we can see the progress in the countries, and we can advocate for the ones who do not have the newborn screening yet. So the floor is yours, Kasper. Thank you.
Thank you so much. Thank you, İpek, and thank you. Well, thank you, İpek, for the invitation and for the introduction. I will quickly move on because I think we've been already talking for 2 hours. This SMA is such a subject that people really love to talk about it, listen about it, and there's so much to know and to learn and to share. For example, today's news is that one of the treatments, Evrysdi, has been approved in the European Union now from birth. This is just received in my mailbox, so sharing with you instantly. But now let's talk about newborn screening, because that was how we ended the previous presentation. And I'll try to show, I hope my presentation will be seen, but please excuse me with technology. Please really need some please understanding that if things don't work. All right, are you able to see the screen? Can you tell it to me?
Yes, we see it.
All right, so newborn screening, I'll quickly move on. No, it's not here where I need to move on. Go to. All right, I'm father of, I have 2 daughters. The younger one has SMA. As I was introduced already, I've been introduced as being a co-founder of SMA Poland, of Treat SMA UK, and I've been helping with SMA Europe since 2014, and recently focusing on newborn screening, both in Europe and in the UK where I live. Conflict of interest is extremely boring, but in my past history, I've been talking to pharma companies, and this normally should be disclosed. My organization is also to accepted payments from the pharmaceutical industry. It was a very generous organizations. So what SMA is all about, I have it on the slide, but I think we've spoken so much about SMA that there is actually very little point to read all of these. But let me just say the SMA is fairly common rare disorder. It is broadly divided into two forms. Yes, I know about types, but this is a bit outdated classifications, but like very broad classification, we have acute course of the disease, or we have a protracted course or chronic course of the disease. So in natural history, acute course is the one where children don't live longer than a couple of years. They deteriorate. They basically don't gain any milestones, and the chronic course is when they reach milestones, significant milestones during the first months of year or years of their lives, and then they gradually lose function. So we have three. The SMA can affect anyone in the world. It's all ethnic groups are susceptible, both sexes, but the incidence varies across the world, and some ethnic groups have lower incidence or higher incidence of specific forms or types of SMA. I'll not go into details now, just signaling it that it is not at all, the whole world is not just like our country. Incidence can differ. People can have different forms of SMA. For example, type 1 SMA is less prevalent in Africa, if I remember correctly, by birth, right? It's just not care, but it's just actually the incidence. There are 3 therapies, as we all know, 3 approved therapies. There are many more in the pipeline. Another couple of causative therapies are in the pipeline and hopefully will be approved sooner or later. Yeah, here let's select these 3 therapies. Nusinersen, onasemnogene abeparvovec, and risdiplam. Let me just go back to the previous slide. Every day we have 12 to 15 children born with SMA somewhere in the world. That's an estimate. But this shows the number of children that should be treated, should receive treatment, should be diagnosed at birth globally. That would be several thousands of children, perhaps like up to 5,000 children a year to be diagnosed and start a young treatment in the world. I will not perhaps read this table. There have been several clinical trials that proved efficacy of all the 3 treatments when started at the presymptomatic stage. The data are quite old. I haven't updated the chart for the last perhaps year and a half. So please excuse me that. But as we can see, event-free survival for all children for all the 3 treatments was at 100%, independent sitting at 100%, walking also close to 100%. Almost all children walked, so the treatments are extremely effective at the presymptomatic stage. How effective they are, let's see. All the 3. Nusinersen. So we have here Oscar, or actually Zofia. We see here Zofia, who has SMA type 2. She was diagnosed prenatally, started nusinersen quite early, and has been taking it for 5 years on this video. Here we see her how she does after 5 years of treatment. We have no signs of SMA. She would normally be having symptoms at around 6 months. And her brother, as we can see, has SMA, advanced SMA. He had symptoms at around 5 or 6 months, and uses a wheelchair to move around. Next treatment, on asemnogena beparvovec. That's not a very recent video. It was shot sometime, I guess, like a year or 2 years ago, but things have not changed. It's still the same excellent effects of the treatment. We have siblings again, 2 sisters. The elder has had SMA for like 16 years on this video, and the younger one was diagnosed prenatally and treatment was started at 1 month of age. She was, I think, 28 or 30 days when she received gene therapy, Zolgensma. So here we see how she's doing. Right now, 2 years later, she's doing great. She has absolutely 0 symptoms of SMA. I saw her less than a month ago. I saw her, I think, 2 weeks ago. It was amazing.
Yes.
So, so absolutely zero signs of SMA. She would be having symptoms by around 6 or 8 months. She'll be having first symptoms and should never be able to walk if not treated so early. Now we have the third child. That's again an old video. I couldn't get new ones because only very recently was invited to make this presentation, but this is the effect of FSD. So Lila was diagnosed prenatally again. Her other brother had SMA, and this is how she's doing at 2 years. She would have not been able to walk if not treated. Yeah. So, as we now know, the sooner treatment is started, the more motor neurons are saved, and the better the outcome. So, if anyone asks, and parents often ask when they come, okay, especially when they learn about SMA, when they frequently call or message me on Facebook, which treatment is the best? Which treatment should I go for? And especially when they're located in countries where there are very few treatments or none. The answer is very simple, the one that can be started soonest. Of course, soonest may vary from depending on the age of diagnosis, on the number of SMN2 copies. Some kids can safely wait a couple of weeks or a couple of months, but others have to start as soon as possible, not seek a different treatment, wait for something else, but start with whatever you've got. And then once the child is secured, you can think about switching if needed, if really needed. So for this reason, we have countries, I apologize, it's map of Europe only, but it should be of this whole world, but I don't yet have such a good picture of the entire world. But we see that the vast majority of countries reimburse at least one causative therapy for the use in pre-symptomatic children. This map, again, is not extremely updated. It says August 2023. I'm sorry because I updated a couple of countries, but I apologize if there are some discrepancies in 1 or 2 instances. But we see that actually universally, we see that countries tend to reimburse treatments in such a way that the insurance coverage covers administration at the pre-symptomatic stage of SMA. That's actually good news because it makes it easier to discuss newborn screening because treatments are already provided. You don't need to, the government doesn't need to renegotiate deals with the pharma companies, which is always always of help. So when treatments were being introduced, we saw a number of testing kits coming to the screening market, I mean to lab. These are a couple of them. These are not all. There are many more companies that manufacture kits that are specifically designed to be used for mass screening for SMA. They use different technologies. They use, for example, qPCR. They can use RT-PCR, real-time PCR. They can use, as we see, the ddPCR, metastases, and whatever. Even you can test, if you wish, using MLPA, and perhaps in smaller countries because it's a rather expensive method. They have all sensitivity reaching 95, perhaps 98%, because they detect mutations except for specific compound heterozygotes, very specific gene, very specific arrangements in the SMN1 gene. They are very specific. You don't get false positives. You get, as I say, like false negatives, around 3 to 5%, 2, 3, 5% false negatives. They are very quick, very fast. It takes between 2 and 3 hours to have a result from the moment you put the DNA sample in the machine to the readout, usually amplified DNA. They can be, and they are very, very cheap. I mean, very cheap. Testing one child is the cost of around €2. Testing one sample is like COVID testing. The tests were like for €2, more or less, sold at €2, 2 or 3 euros. So it's like €2. Some lab costs, you can make it like up to €3, depending on the country, and they cost 2, 3, 3.5 euros. But that's the cost we are talking about. So where we are standing now in the world, because of this low cost, of the wide availability of lab kits, of the high efficacy of treatments at pre-symptomatic stage, we see that more and more countries are starting to screen for SMA. We started with the first country was Taiwan. It started very, very early. They had pilot projects in 2014, if I remember correctly. Then the US, and then Europe is moving on. The green color is where all kids are tested, all newborns are tested for SMA routinely on public healthcare. The lighter green is the majority of newborns are screened. That's usually countries that are piloting universal newborn screening, and they have not extended it yet, for example, to private hospitals. Then we have the orange color, as we can see. These are pilot projects, areas where some hospitals run usually privately funded pilot projects. Yellow ones is something that countries where we expect should start this year or early next year. Oh, I see one mistake here on this map, but it's a minor mistake, no one will see it. Let's see now, area by area. The US, 99% of children in the US are screened for SMA. Nevada is about to start in the next couple of months. The Hawaii are not screening. 72% of children born in Canada are screened for SMA. The large outlier is Quebec, but fingers crossed we'll be on a good way in Canada too. Europe is more complex. Okay, the multitude of healthcare systems doesn't make it easy. As we can see, most of Central, Eastern, and Northern Europe screen for SMA. Sweden, the yellow one, is to start. They were supposed to start in June this year, but I hadn't managed to find any information that they have started. So just to be on the safe side, I've put them like this, also planning to start. The Balkans and the Southeastern Europe are countries with lower incomes, lower health budgets, and sometimes more difficult, more challenging access to treatments. They have not yet started screening. I know Romania is a country where newborn screening is being talked about, but the ministry is having an open ear to the idea. I've heard that Bulgaria might also be looking into it. Slovenia and Croatia, historically, they are very good. They have very good screening programs. So Croatia have already started screening, and Slovenia is, there are some technical issues. They were planning to start. They've been planning for the last more than a year, for the last 2 years. They have not yet started. Surprisingly, the bigger countries of Western Europe are a challenge. Of them, I would say UK is the biggest one. The health authorities in the UK, they think of themselves as so unique and so professional that they prefer not doing anything than doing things. So Ireland is much better, is progressing. We'll really keep fingers crossed that screening should start either towards the end of this year or next year. France has started 2 large pilots. All children are screened for SMA with ground test, and in what's the name of that province near Bordeaux? I'm sorry, I forgot. Portugal is finishing the pilot project, but it's actually all children are screened under the pilot, and we'll be merging it into routine newborn screening now, similarly to Czech Republic. However, Czech is not screening for all kids at the moment. There would be around 90%. So Italy and Spain are very strange cases because healthcare is quite fragmented there. Individual provinces or regions are responsible for newborn screening, so you don't have like equality across the country, but a province can institute their own screening program, much like every state in the US can do. So some regions of Italy have already started screening, others are about to start. Still others are waiting for the ministry, for the central government to kind of recommend it officially. A similar situation we have in Spain. There were more pilot projects in Spain, but still provinces have not started screening, or very few are introducing. There's just discussions are ongoing, and again, on a province by province basis. So these are the biggest challenges. Finland, again, a small country, has refused newborn screening. Then it was resubmitted in 2022, but the case is stalled, it's not moving on. Very, very positive, very bright side was Ukraine, which in the middle of a war decided to introduce newborn screening for SMA. So all children born on the Ukrainian controlled territory are screened for SMA. And Russia also introduced newborn screening for SMA from the 1st of January this year, which means all children being born in Russia and on the occupied Crimea are screened for SMA. Same with Turkey. Turkey introduced screening for SMA, as you can see. So Europe is moving, it still varies from country to country. Still there are challenges, but progress is there. Last year, every month we had a new country or new region starting screening for SMA. Australia. Let's move to Australia now. There are only 2 provinces, South Australia and Tasmania. They are not screening for SMA. Both are Actually, South Australia is expected to start from the 1st of January next year, and Tasmania also is not a there's no fixed date, but they're also expected to start screening for SMA very soon. Of other countries, Japan is piloting. Qatar is screening for like the largest number of disorders in the world. I believe it's in the range of 80 disorders. SMA is among them. China has been piloting screening for SMA, but these were very, very small pilots. And that's pretty much it as regards newborn screening for SMA. Currently, we are at approximately 9.5 million children and newborns being screened for SMA globally. This is a lot. This is a lot of testing, a lot of testing, a lot of lab testing. These are thousands of tests done every single day just to diagnose SMA. But considering that there are approximately 130 million children being born in the world every year, that's a small percentage. That's what's like 8% of the total of all. So what lessons have we learned from SMA newborn screening? Acceptability. There were fears, there were discussions whether parents will be willing to go for a genetic testing, whether there will not be like some apprehension, some fear. Okay, why my child's genes will have to be analyzed, that parents will be refusing. But we've seen it, there have been virtually no impact. It turns out parents don't even read the list of disorders their children will be tested for. That's the case even in countries where they have to legally sign on such a list. For example, in Germany, they receive a very nice leaflet, a booklet that describes each and every disorder that the child will be tested for, and then the parents have to sign them. The refusal rate is, after introducing SMA screening and before, is virtually the same. So this also bodes well for other disorders, genetic disorders that might need to be screened for soon. Incidents. We've seen quite a variability. We see Austria at 11,500, which more rare than expected. Belgium at 1 in 15,000, that's even rare. I was in the study, so the 2.5 years study, so perhaps would fall if the study was longer. Germany was quite good data because of the number of children screened, and same with Poland, it's more than 60 children screened. We see closer to what was estimated for mainland Europe, 1 in 7,500. So this is the number I'm very comfortable with, to say that in mainland Europe, we have 1 in 7,500 children will be born with SMA. This, I think, we can see slightly lower incidence on the British Isles. We might see slightly lower incidence in Ukraine for unclear reasons. And we might see, but no, it wasn't recently confirmed. I initially thought that the Baltics will have lower incidence, but it hasn't been confirmed. It seems that they have very similar incidence to Poland or Germany. I'm very looking forward to data from France once they become available in the next couple of months. Now, a very interesting insight from the Southern Belgium screening project. They detected children in year 1, in year 2, and then in the whole year 3, they detected precisely 0 cases of SMA. They screened 50,000 to 55,000 children that had 0 cases. So it shows like how randomly distributed the cases can be. So this also limits the usability of the data from smaller screening projects or from like short-term data like we got from Austria, or we'll be getting even from France. Another insight is the number of SMN2 copies. I simply copied the data from Poland because they're very nicely presented, and we see the number of copies. The majority of patients had 3 copies. The 2 copies were like less than a third. There have been 5 and more copies. There were 2 children with 1 copy, and 4 copies was almost a quarter of patients. This will be important. I will mention this in a moment. Why 4 copies are important and why 4 copies are sometimes challenging. So what we also learned that approximately 20% of newborns will have early symptoms, and this is something that we did not expect, at least not that many. First of all, it limits the choice of treatments. Well, it doesn't limit the choice of treatments, but it basically forces us to use the first available treatment. Children have to be treated as soon as possible. This comes with additional problem in the European Union that some treatments have different approval scope depending on whether the child is symptomatic or is pre-symptomatic. Unfortunately, EMA made a very, very weird decision. I'm not very supportive of this concept of using SMN2 genes as a criteria for access for treatment application. The SMN2 genes and symptomatic versus pre-symptomatic. We have consequences for health economics because treatments have been analyzed. Newborn screening, health analysis of newborn screening have been carried out with the assumption that children are pre-symptomatic and they will not have symptoms. So there will be significant savings on support and on healthcare, whereas we have now to factor in that a proportion of these children will have symptoms. They will be mild. They will not be life-threatening. They will not require respiratory support, but these children will not be like virtually absolutely healthy with no symptoms. Then the consequences for advocacy. That's a big question mark. Should we keep saying that children will be pre-symptomatic and will live normal lives? I think advocacy has its own rules, has its own priorities, but I think each organization should answer this question to themselves, how to advocate for newborn screening, just keeping in mind that some children will have symptoms. Now, we've also learned that therapies are effective, and we've learned that therapies are effective. We see that children move. I mean, that most children who were treated before the onset of symptoms have no symptoms. Like on this video, we're seeing the video, right? So I'm playing it once again. This girl, she was diagnosed pre-symptomatically and treated pre-symptomatically, and her brother was treated symptomatically. So she is absolutely with no symptoms, and he has symptoms. So, and then the final thing, there is a need of standardization. And this is the lesson learned or outcome of the discussions we had in Amsterdam earlier this year. There was a workshop organized by the European Neuromuscular Center. And these are the lessons just summarized very briefly. We need to improve detection, use standardized technologies, ones that, for example, reliably detect SMN2 copies. Care needs to be given to sample quality. to the avoidance of cross-contamination, to the correct description. Frequently, the issue is that, for example, the child's identity is not well described on the sample. Child often doesn't yet have a name, doesn't yet have a registration, government registration when the sample is collected. So these are all challenges. We need to ensure that samples are stored and not cross-contaminated with other genetic material. The consensus was to detect and report on structural variants, especially variants that might modify the disease or the phenotype. Some of the variants, some of the mutations in SMN1 gene are thought to have an impact on the disease. It's not just a number of copies, but just a type of mutation. Then it was a consensus to detect and report on 4 and more SMN2 copies. Some technologies used are not very reliable at quantifying a higher number of SMN2 copies. So the consensus was not to use them. These technologies, lab technologies, should not be used at all. Also, reporting on SMN2 copies is crucial. Some countries either are not reporting on SMN2 copies or are considering not to report or not to treat for SMN2 copies, people with 4 SMN2 copies. Australia is one notable example. The children who are identified as having 4 SMN2 copies their parents or no clinicians are not even informed of that. Just the sample is just not discarded. The reason is because the government thinks, okay, there is no treatment reimbursed for children with 4 SMN2 copies. Unfortunately, reimbursement in Australia is very restrictive. So they think, okay, let's don't inform parents at all to avoid, I don't know, stress, frustration, whatsoever. And this is a tragedy for many parents, because children will grow not knowing that there is SMA around the corner and that they will start losing function. If parents knew about it, of course, they could consider, buying the drug privately, relocating abroad, importing the drug. Could be anything. Asking someone to send it from countries where it's available at low cost. Yeah, there are such countries. But unfortunately, Sweden was another example. They discussed informing but not treating patients with 4 SMN2 copies. Another recommendation was to develop a good diagnostic therapeutic workflow. How to move a patient from the moment the sample is tested positive to the moment the patient is informed, then to treatment. Because there were risks. There were some lessons that some parents, for example, could not be contacted. Others were told, diagnosis was communicated by a clinician who was not an expert in SMA and was unable to answer questions. Some parents did not believe the child has SMA. They were like saying, no, it must be a mistake. We don't believe in that. The child is healthy. And they refused to go to hospital. They even cut contact with the treating hospital. There are issues of travel for parents who need to be called for a repeat testing, because there are several tests. It's not just one testing. There are 2 or 3 tiers in testing. Parents frequently, right after birth, mothers are frequently unwilling to, or unable, or not good enough to travel, sometimes many, many hours to reach the treating hospital. So like a workflow needs to be developed. As I mentioned, allow early treatment of patients with 4 SMN2 copies. That was also a lesson. And another one was to work on SMA biomarkers that would help us to predict the disease trajectory. So we are moving now, the last few slides, the SMA Newborn Screening Alliance that was founded in 2020, or was it 2019? No, it was 2020. We are awarded with by Eurodis. We got an award. We work towards acceptance of newborn screening. We're trying to help national organizations advocate for newborn screening for SMA. We've published a white paper. It can be downloaded from our website. Please feel free to read it, to translate it into your own language, share it with the decision makers. We are currently, we can help in organizing workshops in your country. We can possibly fund the travel of international experts if you organize such a workshop. We are there as the Alliance. We are also trying to influence EU policies that as regards screening for rare disorders, but perhaps out of the scope of this presentation. Our stated objectives is that by 2025, 100% of children born in Europe are screened for spinal muscular atrophy. For now, we know 99% of children born in the United States are screened for SMA. 72% of children born in Canada are screened for SMA. 92% of children born in Australia are screened for SMA. And 65% of children born in the wider Europe are screened for SMA. Now, how much longer is it going to take for all the children in the world to be screened for SMA and treated early? Thank you. Questions? And please, if you have any questions, the floor is yours.
Are there any questions for Kasper? I think it seemed that your presentation was very comprehensive. So yes, thank you so much for this very knowledgeable presentation. And thank you, Kasper, for participating. As we said, we are going to disseminate the information. We are going to put this webinar on social media, on EMDA's social media channels, YouTube, and so on, because we really consider that everything we have heard in this webinar is important. And when it comes to newborn screening, I must say that it's actually a must, because it's so dramatic when there are diseases that could be, you know, you can just remove the impact of the disease, the symptoms of the disease from the start, or at least alleviate them the way you can. I mean, and not to do it, it's just tragic. I know.
Yeah, I fully agree, Arabella. Yes, yes, this is tragic. It's someone even said that in countries, if the government is not introducing screening for SMA, parents of such children should really consider a class action suit. They should sue the government, because that's the standard of care these days, an official standard of care. Children should be diagnosed at birth. Testing should be done at birth. So, and we see that sometimes children are diagnosed so late that it's too late to start a treatment. It's too late. The average diagnostic delay in the UK is 6 months from the symptom onset to the confirmation of SMA. it's very long. I appreciate some countries might have it shorter, but some countries, especially those with very developed and complex healthcare systems, take very, very long time. Parents are sent from one specialist to another, referred, there are waiting times, and they're just pushed in the system. I've seen a child with type 1 SMA in the UK where diagnosis was suggested by a physiotherapist after 1 year of child being shifted from hospital to hospital, and no one were bothering to test for SMA. Type 1 SMA, the child was diagnosed at 16 months, if I remember. So the first symptoms were like 4 or 5 months. So it's a no-brainer. I think it's a no-brainer. There's no excuse not to have a SMA. It's clinic.
Yes, indeed. I completely agree.
If you have time, I want to share Azerbaijan experience about SMA screening.
Yes, Samad, go ahead.
About 1 year ago, we start SMA screening only symptomatic patients. We screen 40 child, and after that about 15 positive was. And this screening test gives us Roche, which risdiplam produces, and it was very good for us because some patients in Azerbaijan don't have money to pay this diagnostic test, and we screening these patients and we diagnose it. And around Russian countries, for example, Georgia, Azerbaijan, and like these countries, a lot of child diagnoses myopathy, but don't say them you are SMA. And we checked these patients again, and we found about 10 new SMA patients, and these families don't know about it. After our screening program, they know the child is SMA. That's all.
That's extremely encouraging. Samad, thank you for sharing. A big thank you for sharing. I'd love to talk to you about it, perhaps on another occasion, to talk in depth about what you do in Azerbaijan, and what was the situation there?
Indeed, in Azerbaijan, very tragically situation about SMA, because we have very big problems on diagnosis. Firstly, our diagnosis is misdiagnosis. A lot of child misdiagnosed, and we have a lot of child previously diagnosed cerebral palsy. This patient
Wow.
this patient we check again, and we think about SMA, and these patients also we join screening program, and after that about 10 patients we diagnosed SMA.
Yes, right. Yeah. Well, cerebral palsy it shows a spasticity. SMA shows as hypotonia. I have no idea how can anyone confuse the two, but
It's a national problem.
Okay. Right. All right. Okay. But I'll send you an email. Thanks for sharing your email.
I sent you two. I sent you two. My email. SMA,
Yes.
Azerbaijan.
Yes, I saw it.
But,
Thank you.
yeah,
I'll send you an email in the last in a few days, and I will perhaps send you an email also to know more about your organization, and maybe to invite you to our SMA Congress that we, which means SMA Europe, are organizing in Europe in March this coming year. There is a limited number of scholarships available for the representatives of patient organizations. There will be a separate day for patient organizations to meet. There's one full day before the Congress starts, and organization and patient representatives will be able to stay for the rest of the Congress. It will be better than Cure SMA, because in Cure SMA you are not allowed to listen to scientists and clinicians, and in Belgium you will be allowed. With SMA Europe, you are most warmly invited to listen to scientists. So that's it from my end, and very, very, very happy to see that so much interest in SMA, and we see like so many countries. Rudolf, thank you so much for updating about Sweden. Such a huge news, and I didn't get it on my. It must have was published like today, after I prepared the presentation. So Sweden started screening for SMA today.
And I have good news too. Maybe in Azerbaijan from next year we can start therapy. Maybe risdiplam will be. This therapy will be for SMA patients, and we dealing with government for newborn screening, because we know all trials supported that newborn screening is essential for SMA.
It's crucial. Agree. Therapy, you can even try to push the government, because waiting until next year is again, I mean, Georgia, the country of Georgia, your neighbors are already reimbursing risdiplam. Iran is reimbursing risdiplam. And so Azerbaijan, actually, the government shouldn't really wait. If I could be of any help, I just let me know.
Okay, thanks for support.
All right. Thanks.
So thank you once again for your availability and for accepting to be with us, Casper. I think if there are any questions for Casper, any more questions, maybe you could, I think we already got your email, right, Casper? Or if not, they can address these questions in Bucharest, as you are going to attend our conference. So it was an amazing webinar, very enlightening and insightful. I just want to express my appreciation, my gratitude to each and every one of you for taking time to participate. We had with us today patients, patient representatives, medical professionals, as well as pharma representatives. So once again, I think we could see how important sharing information and knowledge among different stakeholders is. And it is really my personal belief that through such collaboration, we can produce faster, significant progress in the NMD field. And again, as Ipeng Ipek mentioned, we want to continue this kind of collaboration. So we again welcome you in person to attend our annual International NMB conference in Bucharest on September 30, October 1st. We can promise most interesting program, so you won't regret if you will join us. Thank you once again for taking the time to be with us, and let's stay connected in the future to help build a better life for SMA and neuromuscular patients. Have an amazing night, evening, night, everyone, and thank you for joining us.
Thank you so much for participating, and I would like to add something. EAMDA covers the accommodation costs of the member organizations and as well as partner organizations. So EAMDA is going to cover that part. The only thing is you should go and register to our website. It is in the chat. Thank you, and I hope to see you in Bucharest. Thank you.
See
Thank
you.
you.
Good evening. Bye-bye.
Thank you. Bye
Thanks
bye.
all.
Bye
Thanks all.
Thank you.
Goodbye.
Bye-bye. Bye-bye. Bye.
bye.
Bye-bye.
Bye.
Bye.
Joachim, are you coming to? Okay, I will stop. Oh, and Joachim left.